and take it over.
Thank you, everybody, and thank you for joining our last of 5 sessions. This is going to be about year end, and this year end is like no other. This year end, the pandemic has really changed the way American healthcare will move forward. So we're going to talk a lot about that. We have the disclaimer here about that all revenue codes or CPT codes here are copyrighted by either the American Hospital Association, AMA, and may not be used without their express permission. So today we'll cover CDM, charge capture, cost management, and the impact of the pandemic. And I'm going to start with source authorities, as I frequently do. I have provided you the outpatient final rule and prospective rule. Now, the reason I give you both is the final rule only gives the comment and what they decide. If you really noted what was behind the thought, you have to read the proposed rule. So both of those are given to you. I also gave you code updates, which are from the AMA, and their specific new vaccine codes. So OPPS proposed that they were going to decrease 340B by 22.5%, renew of the inpatient only list that was being suspended last year, 2.3 adjustment factor, price transparency regulations, and the 2 midnight rule for what was subject to review. In the final rule, price transparency came through front and center with increased penalties required to be machine readable. And there's a lot of new elements in this price transparency. So for all of those that hoped that the lawsuits would stop it, it didn't, and it's moving forward. There's a yearly price adjustment per the market basket. Again, the quality factors, if you do not perform and get to the quality, then you will get a -2%. We had the return of the inpatient only list, and that's because so many procedures went over to ASC, and many doctors in the know and felt that it was not safe to do some of these procedures in the ASC, so they moved them back to the inpatient only list. And there are definitely changes to the ASC list. So there's quite a lot in this year's final rule. Other post-pandemic factors that we have to consider is, one, we didn't start off in a good place. If you look at life expectancy, United States is at 78.6, but Japan, Switzerland, Spain, Australia, France, just about everybody else has longer life expectancy, and that is due to our comorbidities. The other thing that's a big differentiator is our culture. We attempt to get medical care only when we're sick. Not a lot of preventative care, not a lot of outreach. So, for example, NHS in the UK, if you have a newborn, then you're going to get a lactation consultant come to the home. You're going to get a nurse come to the home for as long as it takes. There's no rush to get people out of the hospital because there's no payment associated with the DRGs, the length of stay in other countries. It's all about the quality. So we are seeing the pandemic force us to move closer to other models, not fee-for-service. The debilitating factors in other countries are prevented by encouraging lifelong preventative services. So those that start very early in life. Reimbursement is driven by quality and health outcomes of the community versus the volume of services rendered. So we started off in probably the worst possible outlook. When we look at the Commonwealth Fund, the problem jumps out at you. If you start looking at other countries versus diabetes, hypertension, chronic lung disease, and heart disease, the United States, for all the money it costs us to provide care, by the time we get the care, we have a lot of comorbidities, diabetes, obesity, hypertension, chronic lung disease. We see quite a lot of this that was preventable. When I look at the American Hospital Association report going back to May of 2020 that was issued through Kaufman Hall, we saw at that point 4-month financial impact of $202 billion in losses for the health system and an average of $50.7 billion per month. We also saw that ED claims were then separated into 3 groupings. ED related, non-ED related, and non-ED related surgical. And when we look at that, we saw that our bread and butter with the surgical and the medical for taking care of the patients with those comorbidities dropped significantly off because we weren't able to provide it, because the number of physicians in the United States are skewed towards the specialist and not primary care. So we didn't have the response that we needed. The second thing that happened is we actually have less physicians in the United States than other countries. So the mid-levels have to step up. So after all that, they said the pre-pandemic baseline that many hospitals had, 25% of the hospitals had some sort of negative margin. And they're probably -3-4%. However, the post-pandemic view is 39.2% will have a negative margin, and the pessimistic view has 50% of all hospitals with a negative margin. So obviously, we're going to have to do something or the hospitals are going to go out of business. And that was not, with the CARES Act, this was not completely covered. As per expected, rural health has been severely impacted. They didn't have margins to begin with, and this has made it much worse. So the recovery is going to be based on multiple items, and I've given you the Kaufman-Hall report that talks about what that recovery is. But the key success measure to look for at year end are going to see more primary care, whether that's mid-levels or physicians. We're going to see institute elected procedures again to create revenue. However, revenue is no longer the focus. Population health and cost outcomes are becoming the trend. So while reimbursement is pretty much capped, you have some percentage charge. What the real value now for your margin is controlling your costs, making sure that your costs are all that is the best possible scenario, and also increasing your patient outreach and your patient population tendencies towards better health by using the population health models. We are going to try to move from sick to well. And then we're going to note settings for OP are moving to the outpatient setting. Other things are going to be patient involvement. So we see people like Twistle, and that firm actually has patient involvement for many, many weeks after your surgery. So if you had a knee surgery, orthopedic, it's different types of surgery, but orthopedic, for example, you had a hip replacement, they're going to start interacting with you before your surgery, after your surgery, and then make sure that your outcomes are going well so that you don't have a readmission. So we see that the patient involvement is really now a key indicator in lowering your costs and increasing your margin. We're seeing aggressive programs that address cancellation and no-show rates with data analytics as to what is the propensity for somebody to cancel, and is there a social determinant of care that we have to be looking at. So we're seeing more and more facilities, even though it costs more, they are providing a transportation service. We're going to see more internal controls, especially with data analytics, to make sure demographics and other basic authorizations and eligibilities are taken care of. So what we're going to see is a shift in the revenue cycle from that is financially driven revenue cycle, revenue integrity and compliance. We're going to see a shift now to a clinically driven system. So if we look at this, all of the light blue shaded area are things that need a control point, meaning the next step. So if I started patient access, then the nursing attendant for the visit has to check to make sure the demographics. So each of these steps needs a control point. And we're putting in now green steps down on the lower left to start to do pre-bill to make sure charges and costs are accepted. We see the charge capture audit becoming the standard, and that audit is not happening manually. We're seeing it happen through technology and data. So are we missing charges? Are we overcharging? Is there an overutilization pattern with the residents? What does that look like? First and foremost, because we are behind the times with other countries. We're going to see population health move to the front step. That's number one. It's going to move right up there because we have a lot of contracts, and those contracts actually have qualifiers in them for values. So reductions in CHF or diabetes management or whatever. So we're going to see Pop Health start to take those initiatives with patient interaction with the internal team in the hospital and then external versus making sure that they get to the right level of care. Do they need a sniff or do they actually do home health? But looking at providing the highest quality for the least cost. And this is going to take us right back to what I learned when I first attended school: right patient, right care, right time, right setting, right price. So the 5 R's, they're still together 30 years later. We're going to see more engagement through technology, whether that is telehealth or phone calls or whatever. But the population management is going to see technology to engage the patient. Engaged patients have a much better outcome than those that are not engaged. We're going to try to move away from that emergency room. And what we're going to see is a lot of care now is being provided outside of the hospital or system setting. We're seeing convenience marts. We're seeing more data technology coming into the Walmart plans. We see CVS and others creating their own insurance plans. So we are going to start to see this. And one of the things that should strike you this year is the biggest merger is between United Healthcare and Change Healthcare. So they have some data. United Healthcare has a lot of data on claims. They have a lot of data on patient populations. And so that with Change is going to provide more analytics. So, a company like ours, Health Catalyst, we are in the analytics space. So what we're getting is a lot more CEOs coming to us and saying, okay, we need data and we need good data. So this year, we're not going to have the revenue cycle. We have the clinically driven revenue cycle as we move into 2022, and definitely more data is going to drive that. When I look at my year end, which used to be coding changes and rule changes and what have you, my year end in 2021 is much more complex. I've got the pandemic impact. And if you look at the American Hospital Association and Price Waterhouse and Deloitte, they're all talking about getting prepared for that next pandemic. So this really has CEOs worried. And what they're doing is they're putting in a lot more automation. They're looking for automation to replace human factors, not to replace staff, but to make sure that some of that low-level stuff that doesn't need a human being is going into automation. So you're seeing IT go into the capital budget. We're seeing the cost management is becoming important. Population health, quality outcomes always have been, but now they're going to take front and center. Regulatory coding, and what is the impact on the workforce? So we're seeing a nursing shortage, we're seeing a physician shortage, we're seeing burnout from the EMRs and all the documentation. And so what we're seeing now is increased labor costs because we're depending on travelers and contract labor. We see price transparency. That's not going away, and that has a lot of requirements. And how will that impact our other factors? Supply chain impact. We're seeing hospitals have to buy 2 and 3 months worth of supplies because the supply chain is so disrupted that they need more inventory on hand. Where it used to be a day or two inventory, we're seeing weeks or months inventory on hand. And the same thing with pharmacy because they can't get them overnight like they used to. So this year end looks very different than anything I've experienced in my lifetime. I'm going to focus on the 3 big triad. The triad is always revenue, cost, and quality. One of those levers has to, and many of these have multiple levers under it. So you want to increase your collection rate, cash Excel, payer contract. You want to increase your capacity while decreasing your cost and increasing your quality. So these 3 will now come into play at all points in your clinically driven revenue cycle. In the past, we used to see that it was just revenue. We focused on revenue with our rev cycle and to some extent quality, but not a lot on cost. And now we're really going ahead and we are doing those costs and quality. So we want to look at this clinically driven revenue cycle. I don't know why I'm stuck. And we're going to move ahead from the revenue cycle with a financial focus to the clinically driven. And revenue cycles always focused on back end corrections of errors and omissions. So it was always when I kind of was in the clinical thing, don't worry, you mess up, the business office will fix it. That story has not been around for several years, and it's now impossible in most cases, or very unlikely to be able to fix something on the front end. So now we're going to see revenue, cost, and quality, but it's going to be driven entirely by the clinical practices. So clinicians have seldom been brought into the fold, and now we're going to ask them to drive the ship. With the advent of this type of revenue cycles, we see the drivers begin at the first point of interaction with the patient. So that first point of interaction, okay, what age? What type of wellness checks do they need? Are they up to date with their immunizations? And you're going to do a litany of preventative assessments to see what's going on, making sure that if they're scheduling for surgery, everything else has been taken care of. So has your system ensured that they have all their vaccines, if they wish for them? You know, what about those other things like ultrasounds and what mammogram? Have we taken care of that? Is that already addressed? And then go into the surgical cycle. So now with clinically driven, we're going to see those precursors of preventative care become much more important. More attention is going to be spent to patient access delivery. Most errors are occurring in documentation of the original demographics, especially at year end when insurance cards are not printed. They've changed insurance, or they may have gone on Medicare from a private payer or Medicaid or Medi plan. All these insurances are changing, and it makes it very difficult for the first of the year to know what's going on. So we're going to really have to do control points to make sure that we've checked the morning of the surgery that they have the right one. We're going to consider year-end levers with coding and pricing, cost and quality. And I am seeing still pricing just as disparate as the day is long, having no relation to cost. So I may see an EKG in one part of the building at $110, and another part of the building at $250. There's no relation to the cost. And so we're going to start focusing now on that, especially with hospital price transparency. You want to have equitable pricing. CDM contains many of these elements that have not really been paid for before, but now we're starting to see cost masters where we're driving the patient activity costing, what we find for cost of those procedures and NDCs and supply chain. We're going to drive that back into the CDM. We're going to see the post-pandemic with disruption in nursing and physician practices and expect labor to be a strong consideration in the cost now. Simple example that I've talked the last couple of webinars is the OR preference cards. These are absolute known areas. These are areas of high cost. These are areas where there's decreased reimbursement. And this is areas where there's known wastage for putting a lot of things on the table that don't need to be there. Going back as far as 2012, Cardinal Health said there was about 30% loss in the preference card. Recent studies by OR managers are putting it as high as 50%. So we do have definitely an issue there with, should we be getting stuff out of the supply cabinet at the time it's requested or near the time because you're going to use it versus just putting it on the table? And we see CDRC involved now in OR team, revenue integrity, supply chain providers. We see that in the clinically driven revenue cycle, there's a committee within the OR services, the perioperative services, that involves anesthesia, involves nursing services, involves pharmacy, involves supply chain and IT. And they're saying, okay, let's go through these preference cards. It's been my experience that when you upgrade to a new computer system, the preference cards are either brought over or they're amended at that time. I don't see an active review of preference cards as an ongoing quarterly thing. So that may be something you want to look at. Requested items I talked about being left in the cabinet. And if you eliminate the source of the cost, the provider can still perform the procedure safely without creating the cost. So we're going to start to see the impact of cost accounting. Cost accounting used to take your charges and reduce them to cost by a cost to charge revenue. Now we're seeing patient activity driven costing. So I may consume more resources than somebody else on the phone today. So just to say the cost of this procedure is X is not a true fact. What the cost is now, we need to use patient activity costing and bring it together at a global level. The CDRC has volume, cost, and quality, but it's driven by the clinical practice. No longer is the revenue cycle driving that. You need the clinicians to tell the revenue cycle how they need to drive it. And where I see the biggest impact of this is where we've put in IT systems. With IT has done a fantastic job, absolutely brilliant, created all sorts of wonderful elements to provide the data to us. However, it's not in concert with how the clinical practice actually happens. So one of the examples I'll use right off the bat is we give physicians simple visit coding. And simple visit coding, you may have a diagnosis code, and they pick the top one every time. And so when you're dealing with HCCs and you're looking at trying to work with your revenue cycle on contracting, that's not going to get you there. So we're going to start to see population health, which depends on HCCs. That's going to become more and more involved. So we're going to see the clinically driven revenue cycle take over. What are the stages? First of all, patient access. First of the year, we talked about insurance cards being delayed. We've talked about a lot of times providers are not updated for the insurance company for months after they've actually left the system or something like that. Somebody who was in the provider network suddenly becomes a surprise bill. So you really want to know at multiple steps along that scheduling, is this provider still in? Are they still have the same benefits? Does this insurance cover that provider? So you're going to have to work with the patients long before they come in for the service to make sure that that's correct. Eligibility, you may have eligibility scrubbers in your patient access software. However, they may not be updated yet. You may have to go to a different, like Medicaid or Blue Cross or Aetna has some of their own. You may have to go there. So what is it going to do operationally to you at the beginning of the year? And what I generally see is a 3-month increase in patient access staff in order to be able to do this and get it right. Key takeaways is staffing patterns. They're going to have to be reviewed. If you're still going with minimal staffing and patient access at the beginning of the year, you might need to extend the hours or overtime or something. Additional training for year-end services. Comprehensive testing to make sure that they're using the solutions correctly. One of the things I see a lot of on the 31st and the 1st and the 2nd is duplicate records. So then HIM has to go in and they have to combine these records. So there's a lot of work. So avoiding duplicate records. So control points are necessary. The charge master has become the cost master. And there are many firms out there, including Health Catalyst, where the cost master is something we deal with. It's going to CDM review is going to be new CPT and HCPCS codes, deleted charge, description changes, pricing concern, moving costs into that. Even if it's a cost to charge ratio, it's better than that. And then, of course, doing housekeeping, removing those lines that have not been utilized in 18 months. So I call that just hoarding when you have a whole lot of stuff that you no longer use. So you're going to start by that. Why go and review the CPT codes and everything if you haven't used them? So you're going to have to start with the revenue and usage. And you're going to look for any lines that have very low usage in the last 18 months. Even in the last 12, if they have no usage, you're pretty safe in getting them out. Now, I see a lot of lines, revenue and usage lines with negative numbers where there were credits, obviously to the wrong thing, but a negative number needs to come out as well. So what you want to do is get it down to its cleanest state before you start updating for deleted and what have you. Deletion should be avoided as the CDM is historical. So we do for inactivation. There are some systems out there that still allow for deletions or request you delete it, which is a problem when you come back from historical reviews. When an inactivation occurs, though, you have to go the matching mapping. So I cannot tell you the number of times that I have seen inactivation in the CDM, but the order and the performing in radiology, it's still there. So what you want to do for every single CDM line, you want to trace it through. So radiology is the one view chest x-ray in the RIS system as per the order. So the order go the RIS system. Is there any medical necessity on that? In the RIS system, does it have the right CDM number? I can't tell you the number of audits that I have done because the mapping was wrong. One case was in Texas, a smaller hospital, where they had done 2,500 angiograms in a 8-month period. They didn't even have the equipment. What happened was the mapping. It mapped it to the wrong CPT code. So this mapping is an essential year-end step. A lot of people say, yeah, we updated the CDM, but did you test it all the way through to the mapping? Removing unused items so there are fewer choices, removing order entry for older and outdated orders. Now, if you take the orders away, obviously you have to train the clinical staff as to what orders were there. And if there's any replacement, is there a new selection? Is there a new item? Whatever that may be. Cleaner the CDM for the introduction of new and changes, the better off you are. I see a lot of clinical laboratories at this time provide a list of new lab tests to the physicians and a list of those that are being deleted or how to order the replacement. So I see that with lab. I see it with radiology and some of your specialty areas. Year-end code updates, HIM and CDM have to get together. New CPT codes are actually going on today and the symposium, and they're out there. If you purchased a set, you probably already have the new deleted and changed in your system. HCPCS codes came out last Thursday, so the government has released those. So you're going to start with your deleted code. So first you're going to do your housekeeping, then you're going to do your deleted, then your change, then your new. The reason being is you want to make sure that if you adding a new, is it actually replacing a change? So you're going to have to look at that. The new HCPCS codes should have been in Addendum B with the final rule. And as per the case, they were not complete. In Addendum B, you have to go to the HCPCS code section of Medicare, and you will find the ones released last Thursday. Generally, what I call January is Medicare cleanup month, where you see outpatient code editor changes, HCPCS code changes, but for the most part, Addendum B has them in, just may not be complete. And then those codes have to go over to the clinicians and say, do you do this? Do you have the equipment to do it? Once you know that that's there, then you have to get the either lab information or radiology, OR, pharmacy. You're going to have to get it in there and then trace it all the way through to the CDM and off to the bill. One of the key elements that absolutely has to have claims generated as a stat bill on a fake patient is 100% of pharmacy if units of service are employed. So they have to check that the units of service provided or dispensed comes through the mathematical algorithm that brings it down to billing units. So you're going to have to look at your high dollar chemo, your high dollar bio such as rituximab and infliximab. You want to look at these and make sure the units of service come through a test claim. HCPCS codes I talked about. These are mostly supplies and pharmaceuticals, but you will see some of the J codes change and some of the C codes and the supply codes. You want to make sure that they're. Also, let us not forget the L is in Lima series of HCPCS codes for prosthetics and orthotics. A lot of the orthotics and prosthetics are on the PO schedule, or the prosthetic and orthotic fee schedule. They do not require a DME license, and they are to be billed by the hospital. But a lot of times I don't see the hospital put the 274 revenue code and the L code on, because their CDM doesn't have the L code in it, because they were mistaken. They thought it was a DME and they couldn't bill it. So do pay attention to that one. So supply chain will need to work to ensure that they have the most current coding. So that means you're going to have to look at make and model numbers. You're going to have to look at things that have been around forever. And I'm going to tell you right now, our biggest finding at VitalWare is ablation catheters. There are two types, one for coronary and one for GI. And we see this all the time where they're using the wrong one. We see pacemakers consistently where the wrong pacemaker was charged, where maybe a single chamber rate responsive pacemaker is charged, but the implant log has a dual chamber on it. So the implant log has to match the charge. And I see quite a bit of mapping issues with these pacemakers because they come in on contingency. And a lot of times one will be put in, but it isn't the right one. So be wary of these items of high dollar supplies. Other things, print the stat bills, do the calculations work? You know, are we putting a drug through that has an MUE of 6 and it's coming through as 60? You know, look at your MUEs. Are those calculations right? I know the VitalWare tools do have a calculator to make sure you get your billing units right. Also, this is the time of year to go back and look at your single-use vials and say, do I have JW abilities on this for wastage? Change codes, the new description entails, and unfortunately, most billing systems are limited to 30 to 45 characters, so the description can't go on. Some of these CPT codes have descriptions that are 200 digits long or longer. So we're going to see further specification in the 80,000 series, 70,000. Need to ensure new description is used accurately. In some case, the new CDM line will be created with the requisite mapping instead of changing the old one. And the reason that is create a new one with new mapping and test it, because the old one may not work. So just changing the CDM number on the old mapping doesn't necessarily mean it's going to work. And again, you need the clinicians to come in and say, you know what, we'd never use that amount of drug, or something like that. So pharmacy, we're going to lose on your 340Bs at minus 22.5%. They are still striking OPPS at site neutral payments. So we're going to see the provider base be impacted again. The pharmacy is a general lost revenue year over year, yet it is one of the highest cost areas as far as supplies go, supplying pharmaceutical. Pharmacy is going to have higher costs this year because the inventories have to be kept up to a higher level because of the pandemic supply chain. So we want to focus on pharmacy and clinically driven revenue cycle. I see one for ER. I see one for the rehab. I see one for OR. I see one for the cath lab. So these specialty driven CDRCs really are helpful in getting it all together. Ordering changes in education. The docs, I know when I go to order things on the first of the year, it's like, well, what happened to this test? Where'd it go? What am I supposed to charge in it? So a lot of education or cheat sheets is important in order to know what's not there anymore. And if there is any ability within your system to reference a new test. We're going to talk about cost and pricing. And if you've taken one of my seminars before, you know, this cost slide shows up. And the reason it shows up is it's just so dramatic. I mean, look at the cost we spend on healthcare. I think it's close to $11,000 this year on per capita, when the rest of the world is much lower, but they get better outcomes. So here's other countries. We still are staying pretty high, but our actual outcomes are not that good. In fact, we are one of the most highest mortality and morbidity for newborns in the industrialized world. So this is a problem. We have all sorts of technology. We have less physicians. We have less access to primary care because everything's specialty, and we have more comorbidities that also impact our life. So when you start to see maternal fetal medicine having poor outcomes, that's a generic tracer across the world. They track fetal maternal outcome. And if we're not doing as well at newborn, we're probably not doing as well all the way through, yet our costs are significant. CMS said in OPPS and IPPS that all of our charges should be equitably applied across all payers the same way. So if you charge one thing to one payer, charge them for all. It doesn't mean you can't discount it at the time of billing, but you have to charge it the same. And what I'm seeing are charges that have absolutely no relationship to the cost. And so therefore, we want to start focusing on our charges. Is this just too high? And what we see now with insurance companies is they're singling out their higher cost alternative. So is there a provider in the area that can be a center for excellence that provides all areas of that care, that is cheaper, has better quality outcomes, and therefore the cost is less? So we're seeing them give very poor contracts to those higher cost alternatives. So cost management is now a predominant driving force, and price transparency is showing it up. Enhanced cost accounting and analytics, moving towards outcome and quality metrics away from the volume. So we're seeing the trend showing prices below, cash prices below the insured. So this is a great article of how hospital prices vary. With poor outcomes for the cost, the U.S. is joining other countries in evaluating another model. Another country that's on a fee-for-service model is Australia, but they have actually capped things. So their costs didn't fly up, their prices didn't fly up, but they are also experiencing a significant amount of denials from their biggest payer, commercial payer, United Healthcare over there. So they're looking into how to better manage the process. But the fee for service and fee for volume seems to be an endemic problem in all those countries that apply it. While it's still predominant, we need to have a second second track that's parallel for fee for service to change it to value and quality. So you can't give up fee for service. That's our bread and butter. But how can we start doing a parallel track that involves cost, population health, patient engagement, things like that? Even the Pepper now reports your beneficiary spend per other facilities. So you can easily see where you are against the nation, against your jurisdiction and state. Price transparency has created additional focus on the cost. Yet most facilities have little understanding on what it costs to provide a service unless you're doing patient activity-based costing. So they don't know. The other thing that is coming up with price transparency is end users are struggling with what it means. So they're coming up with generalizations, and it's not that easy. Several models to assign cost in the CDM. We see the reduction of charges to cost through a cost to charge ratio, which is the predominant method at this time. They may have, like, you can go to your cost report and see your cost to charge ratio for the OR, and they take your charges and reduce them because with that ratio. Or the newer model, the newer kind of platinum benchmark, is patient activity-based costing, where it's taking an individual experience and costing it out. And there are many other countries in the world that also do this. So America is not first, but we've never focused on that. We've always focused on the bottom line for dollars. The costs are often assigned additional element in the charge master. So we're starting to see within the line item, we see the attributed cost. And so more risk-based contracts and value-based contracts are going to shift you from charge to cost. So we need to see that. Now, what is activity-based costing? It's consistently different than charges reduced to cost. So on the left, you're going to see 3 patients. They all had the same costs because they all got a charge and they were reduced to cost. However, if I take that and I split it out using the general ledger, income statements, patient accounting, all of these things, and I start to see patient 1, 2, and 3, now I start to see, well, you know what, that OR time for the same procedure by different doctors was different. Oh, the volume of supplies and the volumes of drugs that I need for these patients was different. For the first patient, they didn't really need a lot of drugs. Maybe they just need antibiotics. But patient 2 and 3, you know what? They have chronic diseases. They're going to need more drugs. So as you can see, the right side shows us exactly what's happening and gives us that data for which we can make decisions. The left side is nothing more than a very basic extrapolation that gives you a guideline, but you can make wrong decisions. So end of the year costing is critical. Many insurers now focus on those high cost providers, as I've already said. Activity-based costing allows you to now negotiate with those payers in a meaningful way. So if you're in a risk-based model, where you're assuming some risk, if you don't have activity-based costing or something like it, you're not going to be able to manage that risk as well. So what we start to see is that the risk starts out low and moves higher as the number of years move forward. And we see some groups where they just never are able to deal with the risk appropriately, and other groups where they have very intricate cost accounting where they're able to change dynamically. So we're going to see the strategic insight that this activity-based versus the extrapolation gives. And then with risk reimbursement being capped, your only lever is going to be the cost. Your bottom line is either, if your top of the line is capped, then the only thing you can do is decrease the labor costs and the cost of supplies and what have you. When I'm speaking labor, it's been a knee-jerk reaction of facilities for years to simply eliminate positions. The problem with later on down the line, they may need that position again. You have lost all your business intelligence when you let the person go. And then you have to get a new person in who doesn't have the same knowledge of the system and the way it works. And so there's a large ramp up time. So the knee-jerk reaction in labor is now connected very much to the activity-based costing. Pricing is a demonstrated renewed review or overhaul of pricing metrics. We see price transparency is really changing those into strategic pricing. One clear CMS initiative that came out in the final rule is the CDM must be machine readable. So that was a thing. A lot of people got letters from CMS last year, or OIG. The CDM has to be machine readable in the price transparency. Whenever the cause of 22, you'll see an increase in strategic pricing initiatives. Pricing has always been part of year end. Some methods just include prices for those by volume. So if you have more volume on this particular line item, we'll increase the price to get more charges. Focusing on surgical charges, focusing on room and board by X%, single cost to charge, increase radiology, the whole cost center by 3%. But what we're seeing now is that it's changing from those rote large process. I know CDM software you may pick the Department of Physical Therapy, and I want to increase their prices 3%, and it will automatically do that for you. Now we're starting to see, okay, I want to my cost is increased by 1%, so I need to increase my price by X%. Charge capture management, still the issue is it's not sustainable. There are not policies and procedures on charge capture management. Is it, and who's doing it? Is it somebody in revenue integrity, or does the ownership belong in the clinical department? Mapping within the modules, charge capture areas of concern should have random audit. Patient billing complaints. If you're getting billing complaints, you need to go and look at that line item. And surprise bills are what they said in 2022. Most of the accounting firms say that surprise bills will be the big focus in 2022. You're going to need software, the old reconciliation at the end of the day, because nursing services doesn't usually have time to reconcile all their charges. All the charges need to go into software where you can consume 100% of the charges and also have it spot in the software where you might have missed a charge. Here's an example for the device lookup, and I want to point this out. Here is the same Velos device name, okay? Same manufacturer. The model numbers are different, but if you didn't have the model numbers, what's been routinely happening is you'll use a Velos VR, and that's what you had in stock. So when you get the next Velos, which is maybe a DRT, we're going to give it the same HCPCS code. So being able to look these up and get the right HCPCS code is really a wonderful thing for your supply chain. Here's an example of the knee joints. They all actually have the same thing, but they're different coded. So we're going to start to see reviewing edits. Purpose of supply edits to minimize revenue leakage. Now, I always hear, well, we have our claim edits. We have our scrubber. Claim edits and scrubbers do not look for missing things. They only have algorithms to ensure the things that are actually there are compliant, but they're never going to look for something missing. So now we need pre-bill edits, and that ensures that devices are paired with procedures, and not just with the device to procedure log that went away several years ago. We're actually seeing new technology and what have you. And so in your inpatient rule, new technology is a big thing. So make sure that new technology actually has pre-bill edits if it's used, because it does cause a difference in your payment. And what I hear a lot of times from coding is 3M or whatever tells me it's not going to change the DRG. No, it's not going to change the DRG. What it's going to change is your payment rate. Here's another identification of a missing dissector. Okay. The supply was there, and with the CPT code was there, 49560. However, I don't have any supply. So how did you do it? Here's the example of that. I should have seen C1727 on the bill. Here's another example. If you look at the facility SAF that's present in a lot of technology, especially our VitalWare product, you'll see that if I look up the implantation of mesh, it's going to show me what are those characteristics I should be looking for supplies. So the SAF file is another thing. We want to avoid the charge leakage, okay? So if you fail to make charges, you may not get the appropriate reimbursement, but the cost for providing the service or the supply or the drug was still incurred. So now you've even cut your margin even more. So edits for atherectomy. Here's an example where I put these in upside down. Don't know why I did that, but here's the procedure codes and the with and without. So apologies for that. I'll fix it and send it back out. Here's an example for your software for literature for accurate coding. So I have a Medtronic Silverhawk P4034. Okay, where does it fall in? CMS says it's going to fall into one of these two categories. So you're going to need a lot of help in getting your supplies done correctly. So here, if I see the Silverhawk P36 C1714. So as we close out, because I've got 5 minutes left, we want to look and remediate those pandemic influences. So we're going to have impact on people, process, and technology. All three of those will be impacted. Process-wise, I now have two processes going on. I'm going to have cost, population health, and quality as on one train track and fee for volume on the other train track. The goal is that to have the cost, quality, and pop health kind of intersect or replace most of your fee for volume. While you're doing fee for volume, you cannot ignore the fact you need charge capture. And charge capture means you're going to have solutions and software to ensure that all of your charges are complete charges. HFMA is still saying 1 to 3% of your net patient service revenue is in lost charges. So this did not go away, and it's not going away. So you're going to really have to focus on charge capture and the CDM. Care models are shifting to more outcomes and qualities. So we're seeing some of the voluntary bundles and some of the permanent bundles where there's 30, 60 days post-care where you're going to need to have patient engagement to ensure you're not getting a readmission that's going to cost you against your risk score. It's never good to be the high cost provider. And that goes way back to a Times article. I think it was a Time magazine called The Bitter Pill about 10 years ago, where they compared 3 hospitals in Florida that had very divergent prices that the patients paid. Remember, with high deductible plans being the way that most people are going, or some of the exchange plans where they have more copay, what we want to make sure is that these prices and these costs are fact, because you're going to have to go and collect these things, these higher deductibles. The other thing is there's some hospital studies that say collections at time of service provide a lot more value. Some don't, but I will tell you from my experience, collection on prior to the service on data service or whatever before that patient gets out the door is less money you have to chase after the claim goes on. So try to get those copays and deductibles at point of service. Analytics. You no longer can drive healthcare without analytics. It passed the Excel portion and decision support a while ago. You need hardcore analytics. They're going to be able to slice and dice and pick up trends real time. Population health, it moves to the front runner status. The front end population health, there's whole overarching plans with this, the board, with the community, you know, with your payers. What are you going to try to provide? Are there social determinants to that care? Do I have to interact with that? So now the pandemic has told us that analytics is important. So I know Health Catalyst and several other firms did COVID studies, and they could predict where the next COVID hotspot was going to be, get the hospital prepared, and what have you. These type of analytics have now come front and center. The one thing I will tell you about 2022, beginning of the year, is he who wins will be the most dynamic. So Darwin said it's not the strongest of the species that survive or the biggest or the most intelligent. It's the one most responsive to change. So we see our tertiary care hospitals pretty responsive to change because they have all the analytics, where some of the smaller hospitals don't have the ability to have quite the analytics that they need to be able to change. But this is kind of the overarching theme for 2022. Now, Marie, I have 99 things in the chat box. Is there anything that I can answer? Oh, here's one Q&A.
Yep, there's Q&A right now.
Yeah, what is your recommendation for facilities wishing to cost realign while mitigating what they have significant redundant budget revenue? Oh, wow. So you've got the trifecta. You've got the quality, the cost, and the actual reimbursement. You're going to have to propose a model. And for this, I get Six Sigma groups involved. You know, you're going to look at first patient activity costing. You're going to have to engage in some sort of cost accounting software that does that. The budget revenue. Okay. The budgeted revenue is that in IT? Is that due to your contracts? What is that due to? So if your budget revenue is down because your actual revenue is down, you had a negative margin, you may want to start looking at seeing how much capital is going into IT. Can I use that for analytics, for cost of things? Things like cost accounting. There are things that are capital budgets. You can look at that. The other thing you can do is possibly outsource it. where they're going to do your analytics per charge or per volume or something like that. But it doesn't have to happen overnight. But your cost really has to start to come into play. And the easiest thing you can do is go in your charge master and see if your prices are below APC. If they're all below APC, you're probably going to have a pricing and a cost issue. So the easiest thing to do is go in the CDM and make sure all your prices are at or above APC payments. The second thing is you're going to have to make sure that you meet your payer contracts. So some have CDM increase caps. So did you do that? And then start to work it backwards through these costing mechanisms and supply chains and get some software in for cost accounting. This will probably be in the finance. It'll be in the clinically driven revenue cycle. You don't need to jump to cost like tomorrow, but it should be in your master plan for master strategy for 2022 and see what you can achieve at anything. At the very minimum, get your cost to charges, take your charges and reduce them to cost and get them in your CDM. So there's baby steps you can take. And then there's like, I'm going to bite off the apple and the whole apple and do it at once. Hopefully that answered it. Marie,
Great.
was that it?
That's all that we have in the Q&A right now.
I spoke so quickly. You never know.
Yeah, there's lots of comments just saying thank you and great presentation, but no other questions actually.
Well, it's been our pleasure to provide these to you this year. We wish you every success with year end and in 2022. We know for a fact everyone in America is struggling and throughout the world. So be safe. Have a great holiday season. And thank you much for joining us today. Marie, you want to close this out?
I will. Yeah. Thank you everyone for joining us. Just a reminder that the CEUs and a link to the recording of this presentation and the slides will be sent out by end of day today. If you don't have them tomorrow morning, go ahead and reach out to us and we'll make sure to get those to you. But yeah, have a great rest of your day, everyone. Thank you so much.
Thank you. Bye-bye.
Thanks.